Hello everyone. I hope you're all doing well. Good morning, good afternoon, good evening, based on where you're joining us from. I'm Samuel Fodop, a Cameroonian medical student and a talk fellow, and I'm going to be co-moderating this session with Dr. Nebiyou. So right now, for the interest of time, I'm going to be introducing our first speaker, Dr. Charles Kachungungu. So um, Dr. Charles is a Congolese neurosurgeon. Before I proceed, can you please let me know if you can hear me? Can you please indicate in the chat or
Yes,
with
I'm
a
here.
show of the hand? Okay, thank you very much.
Thank you.
So, Dr. Charles Kachungungu is a Congolese neurosurgeon and graduate of the Sheikh Anta Diop University in Dakar, Senegal. With several years of clinical and academic experience, he currently serves as the head of the Neurosurgery department at Murhesa Neurosurgical Center in Bukavu, that's the Democratic Republic of Congo. He is a leading advocate for the advancement of neurosurgery in the DRC. Dr. Kachungungu is dedicated to expanding access to specialized surgical care. um, he is dedicated to expanding access to specialized surgical care. Through a free medical care initiative, he provides neurosurgical services to underserved and resource-limited communities, ensuring equitable access to life-saving treatment. Beyond his clinical practice, he plays an active role in medical education, teaching at several universities in Eastern DRC and mentoring medical students and young doctors. As a global research mentor with the Operating Room Global, he continues to inspire and support the growth of surgical education and research across Africa. Today, he will be speaking on the topic Building Capacity in Neurosurgery, Challenges and Opportunities in Resource-Limited Settings. So we have a speaker with a blend of research, advocacy, leadership, and teaching. So we're very honored to have Dr. Charles in our midst, and we look forward to learning a lot from him. So Dr. Charles, before this session, I was trying to practice pronouncing your name. That's your last name, and I wish to know if I pronounce it correctly.
It's very good pronounced. And thank
All
you
right,
very much.
thank you. Sure, the floor is yours.
So I'm the first to speak, or what?
Thank you, Doctor. So we have been the first speaker as per the schedule has been Dr. Roland. However, for the interest of time, we introduced you first. So uh, wise for you to continue, and we will continue with Dr. Roland as well if there is no any mismatch with your ongoing plans or activities.
This meeting is being recorded.
Good. The name is well pronounced. Very bad connection.
Recording in progress.
Dr. Charles, so Dr. Roland, can you hear me? If you are there, so we can continue with your presentation. If you hear
Recording
me.
in progress.
Okay.
Hello,
I don't know
sir.
if you can hear me.
Hello, sir. Hello.
Hello. Can you hear me?
Yes, I can hear you. I don't know if I'm going.
Sorry, I didn't get you clearly. Can anyone hear? Oh, can anyone hear me?
But he served at Bamenda Regional Hospital as a neurosurgeon and head of the neurosurgery Roland. It is an honor to introduce. So the floor is yours. You can continue.
Okay, can anyone hear me now?
Sorry for the connection. Dr. Roland, you can continue. You can proceed.
The connection is so bad.
Yeah, the connection is so bad.
Okay, thank you very much, Dr. Nebiyou, for giving me the floor. So I never went through I never got the presentation very clearly. My network has been very unstable. But I presume I've already been presented. I'm Dr. Nchufor Roland. I'm a consultant neurosurgeon at the regional hospital in Bamenda. I'm also a lecturer at the University of Bamenda, Cameroon. So I will be sharing on our clinical experience with intracranial tumors in a low resource setting. So we'll look at a few practical insights and the lessons learned. So to begin with, intracranial tumors, when we talk about intracranial tumors, we refer to any abnormal mass of tissue that forms inside the skull, including within the brain or its surrounding structures. And they can be classified generally as primary tumors if they originate from within the brain tissue or its immediate surroundings, or metastatic tumors if they originate from elsewhere in the body and then they spread to the brain. They can also be considered as benign if they are non-cancerous, or malignant if they are cancerous. We know that in 2019, the global incidence of brain tumor of intracranial cancers were about 347,992 globally. And in 2019, within the same year, we had about 246,553 deaths. That those are deaths were registered from brain cancers and brain and central nervous system cancers. And since 1990, between 1990 and 2019, we have experienced significant increase in the prevalence of brain cancers of about 94.35%. Now, there's certainly a lot of disparities that exist between high-income countries and low-income countries when we talk about intracranial tumors. And we note that the incidence and mortality rates are higher in high-income countries than in low-income countries. Perhaps it's because of underreporting the low and middle-income countries, and also with the higher life expectancy that we notice in high-income countries. We know that the burden of intracranial cancers is more in older populations in high-income countries, while in the low and middle-income countries, there is a significant burden also in children. Most technologies that are used in the management of intracranial tumors within high-income countries are not available in low-income countries. So a lot of the time, management is done within very, very limited means. We are going to be describing the context in a low resource environment. So we're going to, I'm actually describing the context in the hospital where I work. So it's actually the Bamenda Regional Hospital. It's a category 2 hospital. It's found at the intermediate level of the National Health Pyramid in Cameroon, and it serves over 2 million people. It is, by nature, its characteristics, it reflects most of the category 2 hospitals within the country. So they're actually the first level referrals within the various regions in the country. So what are the common limitations that we find in a low resource environment, and particularly in our hospital? We have, in terms of diagnostic tools, we have CT scans. We can do brain CT scans, but we don't have MRI. We don't have pathology. We cannot do pathological analysis. And these are very, very important diagnostic tools when we talk about intracranial tumors. In terms of surgical instruments, we have just the basic surgical boxes. All the advanced technologies that could help us with the management of these patients, like neuronavigation, operation microscopes, intraoperative neurophysiologic categories, intraoperative MRI, all of them, we don't have them in our setting. In terms of anesthetic support, just like for most other regional hospitals within our setting, we have just about one anesthetic doctor to about 10 surgeons. That is quite small. So most of the time, the cases we do are actually monitored by anesthetic nurses. The anesthetic doctor is not available to monitor most of these cases. The post-operative care and rehabilitation, in terms of post-operative care and rehabilitation, we don't have Other forms of physiotherapy, we do just the kinesiotherapy to work just on the motor aspects of it. We lack trained personnel, so most of the personnel we have not undergone any formal training. We don't have specialized theater nurses. We do not have them. So most of the time we have to train the nurses on ground to be able to handle some of these things, some of these pathologies and their management. We train on the ground, so there's actually lack of personnel as compared to the high income countries where people actually, most of the nurses actually get specialized training. Now, in terms of the patients, the caseload over the past 3 years, I've actually been working there just for about the past 5 years. So over the past 3 years, we have had about 46 cases of intracranial tumors that were actually diagnosed and managed right up to surgery. We know that we have had actually more than, totally there have been about 96 cases, but most of them, after a clinical diagnosis, do not proceed to do that. After a clinical and radiologic diagnosis, they do not proceed to do surgery. Sometimes because of limiting beliefs. Sometimes they believe that the brain tumors are actually caused by witchcraft, it's associated to witchcraft, and that the medical treatment, there's no need to operate on someone's brain. So there's some limiting beliefs. There are also financial constraints that prevent them from actually getting to push through with the surgical treatment for most of these patients. Now, if you look at the age distribution here, we have among the 46 patients, we also notice the steady increase in the incidence of the brain tumors across the age. But the particular interest here is the pediatric age group. We also notice that there's actually a significant number, just as we saw for the low and middle income countries. We also have a significant number in the pediatric age group. Our male to female ratio is roughly 1:1. Yeah, we had of the 46 that we operated, we have 23 females and 23 males exact. In terms of diagnostic imaging modalities, we noticed that most of the patients actually they diagnosed with the CT scan. There are cases where we actually needed MRI to have a better picture of the tumor and to better appreciate its relation with neighboring structures, but most of the patients could not afford. Our center does not even have an MRI, so for them to do an MRI, they have to travel to other cities. In fact, in Cameroon, we have just the major cities, the political capital and economic capital that have MRIs, and it's often a challenge for most patients to travel there to do the MRI. And the MRIs are also significantly more expensive than the CT scans, which is a limiting factor for most of our patients. Among these patients, the histologic subtypes that we obtained, we had the majority were meningiomas. This stood at 44%, followed by metastasis, glioblastoma multiforme, and then diploblastoma. We had a series of other tumor types which occurred at variable rates. In terms of referrals, our score with all patients will require maybe microscopy, endoscopy. Most of them will refer them. Things like skull-based tumors and paracellular tumors, we often refer them to the category 1 hospitals because we do not have these facilities at our own center. You have the deep-seated tumors that are found deep within the brain nuclei or the brain stem. They're also referred. We have also engaged in a lot of international referrals lately. We have patients who opt to go to places like India for management because of lack of the available clinical platform to do within our setting. So some of the diagnostic challenges we face, there are often diagnostic delays due to financial constraints and inaccessibility of MRI. So we do not have histopathology services, nor immunohistochemistry services within our region. I'll describe a case where the lack of these things actually influenced the management of the patient. We had about 6 months ago a 32-year-old male who presented with convulsions and signs of raised intracranial pressure, which evolved progressively over a period of about 3 months. We did a brain CT scan. On the left, you can see we noticed this intracranial tumor here. There's the intracranial hypodensity there, which we noticed with a significant mass effect. Now, it was a bit difficult. This tumor didn't pick up contrast. That before and after contrast injection, there was no uptake of contrast. It was a bit difficult to characterize this tumor and to also appreciate its relation to the neighboring structures. So what we requested an MRI for this patient, but they found that they had to travel to get it done. They found that it was expensive. They complained it was going to be significantly affect their ability to even pay for the surgery. So we decided to go in. We took out this tumor. We did a subtotal resection for this tumor. That was 6 months ago. We did a subtotal resection. We sent for anatomal pathology analysis. The results came back and they were very doubtful. So they were suspecting that maybe it's an oligodendroglioma, but it was not very, very conclusive. So we got in touch with oncology services to begin chemotherapy for it immediately. But they too did not want to do it because they were not very sure of the diagnosis. For this patient, we requested them to do an immunohistochemistry analysis. We have no way in Cameroon it is done, so we had to send the sample abroad, but the family could not afford. And then eventually they were discharged and got lost to follow up. And they only returned a few days ago, that's 6 months later, with a protruding mass at the site of the operation. So this is the control CT scan we have on the right. We notice that the tumor has recurred and is now even more aggressive, and that is protruding out there. So this is a clear example of a case where, because of lack of adequate diagnostic tools, the patient actually was poorly managed. So in terms of the surgical management, we have certain criteria to select a patient for surgery. We depend on the tumor location. So at our level, we choose to do tumors that are more superficial, tumors that are found in less eloquent areas of the brain. If we have things at the brainstem, if you have things around the parietal areas, most of the time we don't touch them. So we refer those kind of cases. We also want to select patients with minimal comorbidities, patients with a good Karnofsky performance score, patients with suspected metastasis in which where the primary site of the tumor is unknown. These are the category of patients we generally going for. Outside this, we generally refer them. In terms of the surgical management, there are certain standard neurosurgical techniques which we cannot exactly do them the way they are supposed to be done because of the lack of adequate technical platform. But we have to rely a lot on the anatomy and the pre-op imaging. So we depend on that, and we hope that we don't make mistakes. Once in a while, every now and then, we can touch eloquent areas of the brain by mistake. Since we don't have microscope, we substitute with surgical loops. So that's what we use to do most of our brain surgeries. The pre-operative planning and anesthetic considerations. So all our patients are seen by the anesthetist, so they're actually consulted by them. Even if they're not there, sometimes they need surgery, but they are consulted pre-operatively by the anesthetist. And in case of any concerns, we often discuss the anesthetist and the surgeon to discuss to find the best way forward for the patients. This is another case we did. This was a 21-year-old male. This just to describe a case where we did it just with the surgical loops. So this was a 21-year-old male who presented with signs of raised intracranial pressure and cerebral ataxia, just more lateralized to the left. And it was of gradual onset and evolved over a period of about 5 months. So we're able to, just with the surgical loops, to do a complete surgical reduction. On the left upper and lower images, you see this here, the tumor. So there was this solid neural nodule and a cystic component there, which you see there. So after 1 month, the post-op image 1 month after surgery, here it is within an MRI, and you see the tumor is completely resected. So this is the space where the tumor was actually found. So we came back, the histological analysis it showed that it was a hemangioblastoma. In terms of post-operative care and outcomes, our intensive care units are really not up to standard also. So we just have the basic minimum of things, but at least we're able to monitor the vital parameter. We're able to monitor the oxygen saturation for the patient. We're able to monitor, in fact, the levels of consciousness and so on, just the basic things to keep the patient going. So we're able to do that, and for most of the patients, we're able to emerge from there and get to the regular wards for continuity of care. So in terms of complications, we actually have high risk of infections. Sometimes they can be hemorrhage within the ICU within the first few days of surgery, but we often try to manage that with. So all our patients generally, in case of whether they're infected or not, we put them on antibiotic therapy. We don't do the prophylaxis. We just put them on therapy. Try to cover that. The mortality rates remain high. We are at for those out of those number we did the 46, we're at about 28.6%. We have had patients with significant morbidity too, with residual hemiparesis, we've had patients even with who developed blindness post-op, but those ones are very few. We don't have the full statistics here. So in terms of functional outcome and patient follow-up, in fact, most of our patients, we continue to register to follow them up regularly, and we have quite a good number who get lost to follow up, but a few who are within our reach, we continue to follow them, to monitor them regularly. I think most of them are doing quite well. In terms of multidisciplinary collaboration, there's a tumor board that was created a few years ago, but it's not very effective. So within the board, once in a while we come together, we discuss cases, we bring in all the neurosurgeon. For now, I'm the lone neurosurgeon in the center. So we bring in I'm there, and then we have the general surgeons, sometimes nurses, radiologists, and sometimes we have other bodies who can help to finance some surgeries for some patients. So we do share case discussions with the general hospital, that with the category 1 hospitals for challenging cases. So sometimes we have discussions with the higher level of referrals within the country. For now, we have no partnership with referral centers abroad, and also no telemedicine initiatives for now. So we look forward to that. And then training and skill development of local staff, we regularly do through local scientific meetings. Now, in terms of the ethical and logistic challenges, patient consent sometimes is very difficult to obtain. Like I mentioned earlier, there are patients who, and the carers who think that brain tumors are actually a disease which is linked to witchcraft. So when you tell them that to operate on the head and their brains, they just disappear, they go away, and they don't come back. So sometimes it's very difficult. But over time, as we get to explain to them more and more the nature of the disease, more and more people get to accept brain surgery. And sometimes when they accept, the expectations are very, very high. The expectations are very sometimes unrealistic. They expect that when you put on the next day, the patient will get up on the street running around. So, but we are all of this, most of the time, we just have to manage the expectations in a way that everybody understands and everybody benefits from it. Sometimes we have a lot of financial constraints, and most patients in Cameroon, there are very few people who are insured. So most people have to actually pay for surgery out of their pockets. And it's very challenging for most families to do that. But there are some cost sharing models, like they have mutual health initiatives. There are little NGOs that have created a scheme where people actually deposit money in it monthly or yearly, and then they support to cover the cost of their medical care. That's to a certain percentage, sometimes up to 75%, and the family has to cover 25%. So we have those are the kind of models we have. In terms of resource allocation, sometimes it's difficult to manage the resources. The patients that we have, we need to be able to decide carefully when to operate and when to refer, when to who to operate and who not to operate. Sometimes it's a bit challenging, because in all these, the resources that we have are very, very limited. We always struggle to find a way to balance the resources and the feasibility of the technique that we have to do. So what are some of the lessons that we have learned across these years? That it is important to adapt and to innovate, because we are in the area where the resources are limited. We cannot just fall our arms and say, okay, we don't have the things to work, and finally we do not work. We always find ways to adapt and do the service also for these patients, because most of them cannot even afford to go abroad and get the care the better quality of care that they can get abroad with the advanced technology. So we have to adapt in our setting. We have to prioritize high impact interventions. So we need to do careful selection of cases to make sure that with the limited resources we have, we offer to the cases who have a better chance of survival. So it's important to learn to prioritize high impact interventions, careful selection of cases. We need to do a lot of capacity building and mentorship. Like I said, most of the staff within the hospital, like the nursing care staff, most of them are not specialized nurses. So we need to actually embark a lot on this to help in the near future to be able to build on capacity that help most of our staff personnel to specialize, to train in specific areas. And then we also need to do a lot of community engagement and patient education. Like I mentioned, sometimes obtaining consent is very difficult, but we have noticed that when we educate, we'll talk to this patient more and more about the pathology. It becomes easier for them to accept and give their consent. So the more we engage in community, the more they accept, they understand the pathology, and they also accept treatment. We need to also be able to establish meaningful partnerships with other health structures. You see, we had the challenges with histopathology, we had the challenges with even diagnosis with MRI. We want to have meaningful. In the past, what we've always done is we will collect the samples, the patients or the carers have to take the sample and then travel to another town to deposit it at the laboratory where we can do histopathology analysis. So we need to actually establish connections with other hospitals where samples can be collected and sent. They don't need to displace themselves, and even at a cheaper cost. So what are the future directions? We look forward to improving access to imaging and diagnostics within our setting, to establish local pathology and immunohistochemistry services. I know for the immunohistochemistry it's going to be a bit challenging, but it's a necessary thing that we need to also do here. We need to be able to build telemedicine and remote training programs. For now, I think recently we contacted a hospital in Switzerland, which we're trying to see how we can actually do even telecommunication, telemedicine, and then exchange programs for people to go and train or even to train online. With foreign hospitals, we need to establish partnership with foreign hospitals, both for training and also for patient care. It's also going to help with referrals. Among these people, there are some patients who can actually afford to travel abroad and get their care. If we have good partnerships like that, it's going to actually help these patients. We also need to be able to build on advocacy for resource mobilization and policy reform. And one of the ways is actually establishing networks across different, like what we're doing now in TORG, establishing networks across different operating rooms. Once the networks get big and they're actually solid, it becomes easier to do advocacy to get resources. So those are some of the things we look forward to in the future. Thank you very much. That was a little bit of our experience we've had in the past 3 years with brain tumors in our center.
Thank you very much, Dr. Roland. It has been a quite impressive presentation. And as surgeons, we do know how challenging it could be to work in a resource-limited setting whenever you don't have the means and the tools. Specifically, there are departments where they need integration of a multidisciplinary approach. And one of it is neurosurgery, needing the MRI, neuro navigation, and even after operation, the ICU setup and rehabilitation could be equally necessary to maintain the expected functional outcome after the surgery. So we have seen that under your department, quite impressive work has been done, even with a lot of limitations. And so the floor is open for the participants to ask questions or write in the chat box. So for the participants to ask questions or so maybe if there is no one with questions until then, I might just throw one question. So as a operating room global, we aspire to team spirit and team working in surgery. Surgery is one of the things where teamwork is very important. So what is the role of this multidisciplinary collaboration among the surgeons, the anesthetists, the nursing team, and the radiology department plays an important role in perioperative care of patients with intracranial tumor, because whenever there is a resource limitation, some of the team members may decline some of the things. So you have to fight with the emotional toll and also the consequences or the complications that are going to be expected with under diagnosis and also under treatment.
So
Hello.
in terms hello, I don't know if you can hear me.
I'm not
Hello.
sure if you just heard my question.
Yeah, I think you're asking about the role of the multidisciplinary team, something like that. It was breaking.
Oh, sorry. So I was saying that in resource limited settings, so some of the team members like working in the operating environment, they might decline whenever you are taking patient just for the interest and for the sake of the patient, you might take the patient. But due to the resource limitation, some of the team members, the surgical team members, they might decline to accept operating that patient in that setting. And how do you see this multidisciplinary collaboration very pivotal in improving perioperative care?
Okay, thank you very much for that question. It's what we do is each time we operate on the patient, and we have to sit down and work with the right team. It's true. Sometimes one or two members might want to decline, but since the team, we always discuss and try to get objectively why they're trying to decline. It should not be just because they feel that it cannot be done. So if they have logical reasons why it should be declined, I think we've had cases where we actually cancel the surgery and refer the patient elsewhere. Yes. So, but if the reasons are not really founded, they're not really grounded, I struggle to convince them of on why we think it is possible in our center, and we eventually do it. I don't know if I've answered the question.
Okay, so maybe more question. In the chat box, there are some questions. If
Okay, let me just go to the chat box.
until I explore the question in the chat box, so Gloria has raised her hand. If you are there, Gloria, you can forward your question.
Yes, thank you very much. I'm Dr. Gloria. I'm doing general surgery in training in Ethiopia. Thank you very much, Dr. Rolanda, for the nice presentation. We, as a general surgeon, we need to know about neurosurgery. So I have a question about consent, and they say there is a challenge with patients' consent and expectations. How come the patient's consent is a challenge for them?
Okay, thank you very much, Gloria, for that question. I think what we observed is that some patients they decline surgery because of the limiting belief they have about brain tumors. Some of them believe that it is linked to witchcraft and that therefore it needs to be treated traditionally. They have to go and meet some traditional doctor to do some whatever incantations or whatever to treat it. So we sometimes have a hard time trying to explain to them that no, it's a disease like any other disease and it can happen to anybody. Yes, but so some eventually buy the idea of that it's an ordinary disease that can happen to anyone and eventually get operated. But some still hold on to their belief and they prefer to go home and get treated traditionally. Sometimes I don't know what happens to those patients eventually, but I'm very sure that they don't make it.
Okay, it means that most of patients they have they consult traditional healers before they come to the doctors.
Yes, sometimes some patients do that.
Okay, yes, thank you.
Okay.
Okay, thank you very much, Dr. Roland. So there has been some questions in the chat box, but because my connection has breakdown, so when I rejoin, I just missed those questions. But one of the question has been raised from Samuel was, how can we see task showing of neurosurgical cases to general surgeons in such setup, and also if there is any partnership or collaboration like imaging device companies.
Okay, in terms of task sharing, I think it's very necessary. There are certain procedures that can be actually assigned to general surgeons and even to general practitioners. In my case, since I'm the lone neurosurgeon in the center, sometimes the workload is overwhelming. But I've successfully trained two general practitioners who are able to do certain basic neurosurgical procedures. They can do boreholes and drain hematomas. They do that well, and they can even do craniotomies for acute epidural hematomas. So I'll actually be able to share to send them, and then I give them the task sometimes. Sometimes they do it in my program, sometimes I'm not even there, and they go ahead and do it successfully. I've done quite a good number of them. So I think it's a necessary thing. You need to be able to do task sharing in neurosurgery. The second question, the second aspect was about, I never got it clearly. Something about imaging.
And one was if there is any collaboration or any attempt to do partnership with imaging device companies.
For now, we do not have any partnerships. We do not have.
Okay, okay. So the other was there was no neuro navigation tools. So
No
the other
neuronavigation.
question was were there like neurophysiology or neuronavigation considered to protect the critical structures, injury to critical structures during neurosurgery? If no,
Yes.
so how do you ensure the safety of the surgery?
Yeah, we do not have those tools. We do not have all the sophisticated technology. So what we do, we carefully select our patients. So like I mentioned, those with very deep-seated tumors, close to the basal ganglia, tumors in the brainstem, we avoid them. Yes, we deal mostly with just the either the extraaxial tumors or the superficial ones, the cortex. Those are the tumors we deal with. And we base ourselves a lot on the anatomy. We try to just follow the anatomy as much as possible. It's true there have been one or two cases where we have had to touch eloquent areas, but we try as much as possible to avoid them. Just with
Yeah,
anatomy.
pretty sure. Yeah, pretty sure. Even with like beta imaging devices and the presence of beta imaging devices, if there is no neural navigation, you might be patient selective, and then posterior fossa tumors, you might not just approach those kind of things without such device or beta imaging approaches. So it has been an honor hosting you. If we could have time, there could be like a lot of questions which has to be raised, because this is very challenging, even and better setups. Even neurosurgery is very demanding and challenging, but also rewarding discipline. But still, we need to appreciate to our physicians and doctors who are just didn't sit back, even with the lack of very necessary resources. So thank you very much, Dr. Roland. For the interest of time, we'll be moving on to the second presenter, Dr. Charles. If you are there, we can proceed to you. And if anyone in case do have questions to Dr. Roland, you can put in the chat box, and we will be getting back at the end of the presentation. Hello, Dr. Charles. Can you hear me?
Yes, I can catch you. Good morning, everybody.
Thank you very much.
And,
sorry for the
yes.
inconvenience. We can continue.
Yes, thank you. Let me share my screen, and then we can begin. Okay, can you see me? Hello?
We're just about to share. The screen is not yet seen.
The screen is not yet seen. Let me see.
Yeah. Yeah, it's
already.
It is there now.
Yes, okay.
It is there now.
Thank you very much.
Yeah.
Thank you very much. So I'm very happy to discuss about how to build capacity in neurosurgery in resource-limited setting. So this is the plane, the following.
Yeah, so you can just put it on the slide mode.
Yeah. Let me see slide mode. Okay, is it good? Yes, from introduction to conclusion via challenge and opportunities. Important to say that, to note that more than 5 million neurosurgical pathologies are diagnosed each year in resource-limited country, but the majority of them go untreated because of insufficient resources. Our objective is to identify the main challenge and the possibility to address them, organizing African community to pool their resources in order to facilitate access in tertiary health care.
Sorry, Doctor, the slide is not moving. Can you try it again?
This one.
The slide is not moving for us.
Okay, thank you.
Now you can just make on the slide view and yeah.
Yes, I'm coming.
Okay.
Let me, because I'm not sure that a little problem. Screen. Diffusion. Not coming. Let me change the screen because this one is making trouble.
Okay, you can share it again. Can screen share it again? Yes. Yeah, you can screen share it again.
So let us see if possible to make something. Can you see me?
Yeah, it is visible. You can continue. Just go. You can continue.
Okay, thank you. Let us do like this. So this is the plane from introduction to conclusion via challenge and opportunities. Alors, est-ce que ça avance? Alors,
yeah.
Okay, thank you. Okay.
It's moving now. We can continue.
Yes, let us note that more than 5 million of neurosurgical pathologies are diagnosed each year in resources-limited country, but the majority of them go untreated because of insufficient resources. So our objective is to identify the main challenge and the possibility to address them, organizing African communities to pool their resources in order to facilitate access to tertiary health. Alors, to achieve these goals, we face several challenges. First, limitation, the human resource limitation. We observe migration of trained specialists to better endowed countries. In 10 years, I observed 6 young neurosurgeons who have dispersed around the world, you see? And because of more difficulty to practice locally, we have also very limited training program that expose our patients to subspecialty. I don't know if you, yes, good, nice. The second challenge is lack of neurosurgical infrastructures. This is a big problem. And inadequate surgical tools and sterile supplies. The financial constraints. The financial constraint is the third challenge. Yes, the lack of insurance coverage and insufficient public funding and competing health priority. So this is a very, very, very big challenge in poor countries. You see, in Congolese hospitals, in Congolese countries, in Congo where we are practicing. Next is the geographic and logistic barrier. Most of neurosurgical centers are concentrated in urban areas. So we observe delays, referrals due to poor transportation and communication. Finally, the minimal research capacity. The minimal research capacity limiting evidence-based planning. However, it should be necessary to note that it's possible to develop neurosurgery practice in underdeveloped countries, in Congo in particular, in making training and workforce development. Donc, local training program expand neurosurgery residency and fellowship program within limited country, within poor country, and in Congo in particular. To tax sharing. Donc, tax sharing is, I think it's very good. It's good to train a general surgeon in making basic neurosurgical procedure, like to make shunt in hydrocephalus, or like to take some emergency trauma, to put out an extradural hematoma or subdural hematoma, like that. Donc, to make some basic neurosurgical procedure, very necessary to be efficiency. Secondly, it's very important to strengthening infrastructure pass by using low-cost innovation, like this C-arm. I bought this C-arm low-cost in France lastly, only 500 euros. So we need to have information how to buy some tools low cost. We need information. We need to share information with hospitals in Africa, how we can buy some tools low cost, not necessary to go news one. We can buy some instrumentation without expending so much money. Also, we need to use telemedicine for remote consultation or to make some case discussion and follow up of patients, to exchange with patients, to exchange with other colleagues, medical neurosurgeon or others. We need to promote telemedicine. The big challenge is policy and advocacy. We need to integrate, how to integrate neurosurgery into national programs in Africa. Very big challenge. How to advocate for government investments in health insurance promotion, to facilitate access to care, and for hospitals to increase recovery rates, a major factor of economic growth. When a hospital have economic growth, it will have also possibility to buy tools, you see. So it's very important to promote in Africa. I don't see if you are catching me very well. Very good to promote in Africa, to advocate for government investments in health insurance, because health insurance facilitates access to care and access to care for patients, and also facilitates hospital to increase recovery rate. When recovery rate is increased, the economic growth of the hospital is also ensured. I don't know if you are wrong. The last opportunity is to build network of institution in low country in Africa, to build network, to share learning and to share multi-center studies. Let me give an example. The example is, as we can see in this, I don't know if you are, hello?
Yes, we can hear you.
Thank you very much. The warm welcome we received from IRCAD delegation under induced influence of TORG confirm commitment of TORG, IRCAD, and the Murhesa Neurosurgical Center to strengthen neurosurgery in Africa. I think it's good to promote this kind of partnership between institutions, and also to interest others, like you see Global Federation, World Federation of Neurosurgery, in partnership with other organizations, to share knowledge and to share information to promote so that we can to promote neurosurgery in poor countries. In conclusion, despite major challenge in resource limited setting, innovation, collaboration, and policy commitment can significantly strengthen neurosurgical capacity in poor countries. Congo is particular, is one of the countries who need to be promoted in neurosurgery. We are thanking you and eager to welcome you to Bukavu, DRC in 20 26 for the Congo. Thank you very much.
Thank you very much, Dr. Charles, for that wonderful presentation. That was amazing. If you have any questions, please raise your hand, or you can type in the chat box. So in the meantime, Dr. Charles, so over here in Cameroon, one of the main contributors to traumatic brain injury, which is one of the pathologies neurosurgeons encounter often, is road traffic accidents. So when talking about preventive strategies, you didn't say much about public health policies or policies to reduce the incidence or the prevalence of road traffic accidents. So I wish to find out, the road traffic accidents not contribute very much to traumatic brain injuries in Congo as well.
Is it a question or?
It's a question about the burden of road traffic accidents in
yes, traumatic injuries is one of the most frequent pathology in Congo. Brain injury or spine injury, one of the very frequent pathology in Congo, in Bukavu particularly. So I think I'm suggesting to train general surgeon to make some basic neurosurgical procedure, like to burr holes or to shunt insertion, or if possible to make an arthrodesis in a luxation in vertebra. It's possible also to make, or to make a laminectomy. Donc some basic neurosurgical procedure, it's necessary to train some surgeon, general surgeon, or some to make a such basic neurosurgical procedure.
All right. Thank you, Dr. Charles. Dr. Nebiyou has his hand up. Maybe that's a question, then I'm sure he would give closing remarks and conclude. Dr. Nebiyou, over to you.
Okay, thank you very much, Dr. Charles. So it has been quite an honor to hear the solutions and the challenges you have been raised. So yeah, sure. Of course, it's not only neurosurgery, but surgery is taken as a neglected stepchild of global health. There are a lot of policies whenever we talk about global health, but for surgery, it's more or less taken as a luxurious care, a cost-effective care, sensitive care, and also complex care, but still without surgery, you cannot achieve universal health coverage. You cannot talk about global health as well. And specifically with task sharing, with the current trend of like neurosurgical use, for example, if you take low back pain, researchers project that by the year 2050, about 800 million people in the world will have low back pain. So, and also tumors are on the rise. So if we're just thinking to continue or producing limited number of neurosurgeons, maybe it might take us like 200 or 300 years, although it needs a modeling study. But task sharing has its main effect here, because as general surgeons, we've been doing hematoma evacuations, craniotomies, specifically this trauma case. And as you said, for example, in South Sudan, general surgeons have been doing shunting. And as you said, with short-term training and capacity building, general surgeons, they can do also arthrodesis and also laminectomy. So I think on the policy and advocacy side, we have to speak very loudly about task sharing and sometimes task shifting as well. And saying this whole, so as practicing in the DRC, so the challenges we have raised are in place, but what were the solutions you have been looking for, and what were the solutions you have implemented so far, which could be serve as a model for other countries and nations or setups?
Okay.
Dr. Charles, are you there?
Yes, I'm there. Yes.
Yeah. Yeah. If you get my question, you can go ahead.
So I think it's important to recognize that to take care of emergency in neurosurgery is asking to have a number of neurosurgeons who is enough and sufficient to take care for the population. You can see that the number of neurosurgeons in Africa and in poor country is very, very, very less. It makes that neurosurgery become in existence. Don't exist. I can say that the neurosurgery don't exist in Congo particularly. I can take an example. In Bukavu, we can have five in South Kivu, 5 million inhabitants minimum. But for the 5 million of inhabitants, we have only 3 neurosurgeons. And maybe 1 neurosurgeon for 2.5 million of people. It means that neurosurgery doesn't exist in this community. So we need to have to learn more, to train more. But before training, we have to share with other surgeons, to train a general surgeon to practice emergency in neurosurgery. Donc, this is the task sharing, you see, so that the population could be well treated, minimally well treated. Yes, that's my preoccupation. For Congo, we need to first to task sharing, and after that to train, to accelerate training of young neurosurgeons, so that in a few moments we can have a number sufficient of neurosurgeons to treat a population. But to arrive there, and to prevent migration of trained specialists, we need to treat with government to advocate for government investment in health insurance promotion, so that patients could have facilitation to access care, and also hospitals to increase the recovery rate. For majoring factor, the major factor in economic growth. When economic growth of the hospital is effective, the hospital can be able to buy materials and to promote also everything. I don't know if I'm a little clear that is on this. Hello? Are you catching me?
Yes.
Please?
Yes, sure. That's well addressed.
That's my preoccupation, yes.
Hello, everyone. Thank you so much, Dr. Charles. Thank you, Dr. Roland. This is Prof. Adebusola. Greetings from Ireland. Thank you, everyone, and thank you to our speakers for the insightful presentation. I believe a lot have been said, especially the fact that there are clinical realities of neurosurgery, especially in low resource settings, but at the same time as well, just as someone mentioned in the comment section, section that despite all those challenges, our neurosurgeons, they've been outstanding. You can see what has been done already, even if it's referred to a higher facility, or to make sure that even the resources can still help and support someone as much as possible. So I believe a lot has been said in this meeting, but we still have a long way to go. For TORG, I know we have been involved in capacity building sessions just like this one that we are having, even partnership. We have partnership with Harcad Africa, just as Dr. Charles mentioned, on behalf of the center he visited recently with his team from the Congo, and they were welcomed as representatives of TORG to the center to see how they can facilitate training and more. So a lot needs to be done in terms of partnership, in terms of advocacy. You know, Dr. Roland also mentioned in his presentation, there is a need to partner with institutions in high-income countries that can support, even if it's equipment-wise, training-wise, doesn't have to be in person. It could be remotely as well. Telemedicine is needed. So I believe we need to look into that in the new year. Neurosurgery is one of our priorities, general surgery and orthopedic surgery. Most importantly, those three aspects would be our priorities in the new year, and even research as well. So basically, can someone hear me? I think I'm hearing sounds in the background. I'm not sure if I'm still audible.
No, we can hear you.
Okay, thank you. Okay, thank you so much. So those three specialties basically are going to be part of our priorities in the new year, especially in research. I believe even for this session, we tried as much as possible to get neurosurgeons join us from the US and 2 from the UK. But unfortunately, they couldn't make it today because they had other emergencies to attend to. Otherwise, we would have heard their insights and we would have seen what actually worked for them, and they would have been able to link up the African ones with the high-income ones. But we won't give up on that anyway. We'll continue to press and see how we can foster more partnerships that can support neurosurgery in low resource settings. We could see as well, like Dr. Roland mentioned, his loan in his department, in his hospital. Can you imagine that? And most countries are like this as well. You could have one neurosurgeon in the entire country. You could have 2 neurosurgeons in the entire country. Some don't even have as well. And I'm aware that the Murhesa in the Congo, they have a case that requires skull-based excision of tumors, and they need the resources for that. They need training for that, and currently it's not available. So there's a long way to go. As I've mentioned, we are not going to give up as TORG. Just as Dr. Roland mentioned, as part of the role of TORG is to keep expanding the network until we can gain sufficient visibility to partner with those who matter, those who can make things happen. And even though funding is required for most of these things, I believe visibility and advocacy such as we are doing, such as begins from now, It's going to go a long way to help and correct things as well. I believe some of the community are also watching this on YouTube, and some key stakeholders would still watch this session and maybe come back and say, oh, we want to support in a way. What can we do? And what can we do to help? So I believe if you are listening to this and you think you can support neurosurgery training or capacity building or research in any way, please feel free to reach out. We will be happy to link you up with Cameroon, Bamenda, Dr. Roland, and with the DRC as well. That's the Murhesa Center in the DRC. Unfortunately, Murhesa is our the national hub of TORG in the country. So feel free to reach out, and I believe we can achieve this. So I believe in the new year, we need to continue to collaborate. We need to continue to share knowledge, and especially across borders, to aim at strengthening surgical systems, not just in neurosurgery, across other specialties as well. So I just want to say, before I hand over back to the co-chairs, I want to say thank you on behalf of the Operating Room Global TORG. Thank you to Dr. Roland Nchufor. Thank you to Dr. Charles Kachungungu. Thank you for your expertise. Thank you for the real experiences that you have shared. And thank you to our excellent co-chairs, Dr. Nebiyou and our student, Dr. Samuel Fodop. Thank you for your leadership in moderating this session. I want to say thank you to everyone who connected, for taking the time out of no time to connect. I know it's not easy. Even recently, just a few days ago, the time zones changed. For us in Ireland, we've moved like an hour backwards. It's not the standard time of the webinar. So I really want to say thank you to everyone who made it, despite the challenge. Sometimes network issues is not something we have control over. I always say that people could be connected, they could disconnect, and yet they will try to reconnect again just because of their commitment to this. So I really want to say thank you so much, everyone. And now I'm going to hand over back to the co-chairs to continue the session. Thank you, Doctor. Over to you, Dr. Nebiyou.
Thank you very much all for the attendance and the speakers for the presentation. Of course, when you read textbooks, you might get information and learn from there. But learning from challenges and from I mean systems and infrastructures, and also the live patients, of their patients and experiences in the same setting and resource limited setting would be another level, because they're teaching us from their experience, and we have seen that the neurosurgeons, they didn't sit back, but they tried their best, and still they're serving even with the absence of the most important equipment like CT scan and pathology and so on, neuro navigation device. So what we learned today is that even with the absence of equipment, we shouldn't always talk about the problem, but we should curve and try to look for the solutions and try to serve the community at hand, balancing the ethics and the safety of the patients and our service. So thank you very much. This is a very insightful and very important presentation, and we will continue to bring consultants and speakers and teachers who could teach from their experience, not only from the textbooks, from their experience, from their challenges, and from their management and outcome of their patients, so that we can live in that reality and serve the community in a better way. And we will also try to excel at talks, bringing both local and international experience. So stay tuned for our next webinar. Thank you very much, everyone. It has been an honor to have you all. This is all what I could say. Have a good day, a good night. See you next time.
See you, everyone.
Thank you very much.
Thank you so much.
Thank you.
Bye.
Thank you very much. Thank you.
Thank you.